Nia for such a nice presentation. Now I would like to call Dr. Erum Ashraf. She recently did a FCPS Part 2 and she is going to present common manifestation of mycosis fungoides in Pakistani population. Dr. Erum Ashraf.
Bismillahirrahmanirrahim and Assalamu alaikum. So I'm Dr. Erum Ashraf from Institute of Skin Diseases, Karachi. I'm here to share with you an interesting case study which is about a rare but an important cutaneous malignancy called mycosis fungoides. As we know that mycosis fungoides is the most common variant of cutaneous T-cell lymphoma, while Sézary syndrome is the aggressive form of the disease. It has an indolent clinical course where the disease progresses slowly over months and years. The clinical presentations of mycosis fungoides are variable, and that's the reason why these patients are very often misdiagnosed, as this disease mimics common dermatosis like psoriasis, eczema, and infections like tinea corpus and many other common dermatoses. And even histologically, in the early disease, the histology is sometimes very misleading. So these patients are treated as such for months and years by general practitioners, and finally, when these patients develop typical cutaneous lesions, then they are referred to consultant dermatologists for further workup. So we did the literature search about this disease, and the data regarding the status of MF in Pakistan is insufficient. And unfortunately, to date, there is no detailed clinical pathological study or published literature on mycosis fungoides in Pakistan. So we decided to study the different clinical, pathological, and immunophenotypic features of mycosis fungoides. We planned a study that was a case series. The sample size was of 10 patients, and it was done in the dermatology ward of Civil Hospital, Karachi. It extended over 4 years from January 2013 to December 2016. So here are the results of the study. This chart very well summarizes the results of the patients, and to see in detail here you can see that the blue bar, it shows the age of onset of the cutaneous lesions, and the red bar, it shows the age at which they were diagnosed. So for example, looking at the patient number 1, he started developing cutaneous lesions at around 50 years of age, but he was diagnosed quite late, at around 75 years of age, with the disease. Some patients, like patient number 2, 4, and 6, are comparatively younger patients of the series, among which patient number 4 is the youngest patient who started developing cutaneous lesions at around 20 years of age, and he was diagnosed after 12 years, at 32 years of age. Most of the patients were diagnosed late. Patient number 7 is the oldest patient of the series. She developed skin lesions at around 62 years of age, and she was diagnosed very late, at around 80 years of age, which itself carries a very poor prognosis. So we calculated that the mean age of diagnosis of these patients was 55.7 years. We also calculated that 80% of our patients were males and 20% were females. 70% patients were above 50 years of age, and 30% were younger than 50 years of age. So here you can see the clinical presentations. 30% patients presented with scaly erythematous plaque, 30% patients had presentation with erythroderma, 30% with tumors and nodules, and 10% with other presentations like poikilodermatous skin. The initial diagnosis these patients came in with, 10% they came in with the diagnosis of eczema, 10% patients 40% patients came in with the diagnosis of psoriasis, 10% patients came in with the diagnosis of cutaneous leishmaniasis, and these were the patients who presented with ulcerated cutaneous nodules, while 40% patients they presented and they were diagnosed with mycosis fungoides, and these were the patients who never got any treatment, and they presented for the first time to us. Now sharing here some of the pictures of our patients. On the left side, the first picture is of a patient who was an elderly male and who was diagnosed as a case of tumor d'Amli. As you can see, there are multiple nodules on the face and neck, and there was no previous patch and plaque stage. So he was in stage 2B, and he was referred to chemotherapy, to which he very well responded. The second patient, he was an elderly male who was in erythrodermic phase, who was later diagnosed as MF. The third patient, he was a younger male who initially had presentation with erythroderma, and later he developed a nodule on the lower abdomen, and that was consistent with microvoides. Unfortunately, the patient was very non-compliant, and he was lost to follow-up. As he So the first patient here, you can see that he was an elderly male who presented with erythroderma, palmoplantar keratoderma, and flexion deformity of distal interphalangeal joint. And for a longer time, for years, he was diagnosed as a case of psoriasis with arthropathy. The next patient, she had typical erythematous scaly and atrophic plaque and plantar keratoderma. Another interesting case, on the right side, an elderly female who had initial presentation with erythroderma, and later she was diagnosed as a case of poikilodermatous MF. So we also compared the histopathology of our patients, and the characteristic features of mycosis fungoides as atypical lymphocytes present in sheaths with convoluted nuclei were present in all the patients, though portrait microabscesses were not seen in any of them. Epidermotropism was seen in half of the patients. TCR gene analysis could not be done because of non-availability. Immunohistochemistry was done, and the results were consistent with mycosis fungoides. As you can see, positivity for CD3, CD5, CD45 Rho. So after all the careful workup, we did the staging for the patient. 10% patients were in stage 1B, 20% in stage 2A, 30% in 2B, and 40% in stage 3. So there were more patients in the later stages. So here, this study highlights the various clinical pathological findings which were exhibited in our patient. The mean age of diagnosis, as I mentioned before, was 55.7 years, and that was also comparable to the Western data, as there was a study done by Regna and co-authors in the year 2002. And another study done by Nita Sali in the year 2009. Male preponderance of 5:1 noticed, and which was also comparable to Western data. The majority of our patients' duration from onset of disease was about 12 to 20 years, and which was similar to a study done by Derma in the year 2002 that also showed a long duration between onset and diagnosis of the disease. 50% of our patients had lymph node involvement, but none of the patients had distant or any other organ involvement. So I conclude that the diagnosis of mycosis fungoides can pose great difficulty, as its clinical presentation not only varies according to the stage, but it also mimics a number of other common dermatological conditions. So our take-home message is that the knowledge of this rare disease entity and its variable presentation is very crucial, as delay in referral and timely diagnosis commonly adds to the patient's morbidity. And I end by saying that we need similar but better studies on a larger scale to see the clinical pathological profile of the disease and also prevalence in our part of the world. Thank you.